Rory Spiegel and Ryan Radecki.
Welcome all. We are back again for another month. If you can't tell, one of us has been stricken down with COVID for a third or fourth time. It's a little unclear.
I can't believe this. I still haven't had it once.
I know. It's terrible. It's just this time it took my voice, and it's been 2 weeks without a voice. It's finally starting to come back, but if you can see my staying power with conversations is somewhat limited. So we should probably just jump right in before I lose it altogether.
They always say never apologize for a presentation, Rory.
Well, this time might be different. All right. Well, why don't we get started? Because I don't know how much time I actually have before I lose it completely. So the first article we're going to be discussing is the impact of pain assessment on the Canadian Triage and Acute Scale Prediction of Patient Outcomes. And the lead author is Lars Grant. So this is a bit of a strange one, I thought, but the authors essentially examined how the addition of a pain score and the ability to treat that patient's pain would affect the ability to predict admissions, ICU admissions, and mortality in the hospital. They essentially did a retrospective observational study, taking all patients who visited the emergency department and basically looked at the ability of the Canadian Triage Acuity Scale with or without the addition of a pain score to predict outcomes. Overall, they looked at over 229,000 patients. The average reported pain score was 5.6 out of 10, and about 60% of the cohort had pain altogether. And basically, the pain score didn't really add much to the triage score's prognostic abilities. The area under the curve for pain-free triage score for hospital admission was 0.691 compared to 0.641 without the pain score. And ICU consultation, mortality were all about the same. There were small statistical differences, but it didn't really make a difference in a clinical situation. So for me, this is not so surprising. As they demonstrated, a cohort that presents to the emergency department basically comes with a large proportion of them having pain. And most of this pain is benign and some of it is not. And the trick of emergency medicine is deciphering which of this pain is due to a serious etiology and which is not. The ability to treat someone's pain does not necessarily help in this endeavor of triaging what's serious and what's not. So I don't think necessarily that whether you can treat someone's pain or not predicts outcomes, and this study kind of shows that.
Yeah, and I think we should also just be realistic about what the CTAS algorithm is meant to do. The triage score is not meant to predict admission necessarily. That may be a secondary sort of, effect of the score, but the main goal of the CTAS algorithm is to describe how much time it takes to have a contact with a physician, and somebody who is describing severe pain ought to have a faster contact to a physician or a medical professional, regardless of whether they're going to be admitted. I mean, we send lots of kidney stones home. Kidney stones are furiously painful. And they should have contact with a physician sooner, even if somebody is going to ultimately get admitted for their, say, appendicitis or diverticulitis. If they are in less severe pain, it may be more valid for them to wait to be triaged by a nurse, have things started before having contact with a physician. So let's just not try and expand the role of this triage score beyond what it's really intended to do.
Yeah, that's an interesting thought. I hadn't thought of that. So you're saying like maybe if they looked at different outcomes, like time to seeing a patient, time to seeing a physician, time to pain medication, they might have had different results.
Well, I mean, in theory, that's what the point of the triage scale is for, isn't it? I mean, some of it is obviously acuity of presentation, and it's the potential for deterioration that gives people a triage score of 2, and then you have the severity of the pain and the amount that somebody is writhing, in suffering. If you've got bone sticking through the skin, you've got an obviously displaced, ankle. Not all of those people are necessarily going to get admitted. They may get reduced and sent home, but they definitely need to see a physician sooner than later. Just because of their pain. So yes, there's other things they could have measured here that might have been a better correlation with the pain score and the triage score that may have reflected the role of pain in the triage.
I still think in America, most open fractures get admitted to the hospital.
Well, but you could have a dislocated elbow that you end up splinting and sending home. That patient needs to be in a room and get a little either nitrous or propofol or ketamine or whatever you need to get them to get their elbow back in place. And they could probably be splinted as long as they're neurovascularly intact and sent home. But I would say that's a good one for a triage too.
Why don't we move on?
Yeah. So this next article we're going to talk about is called Opioid Prescription Reduction After Implementation of a Feedback Program in a National Emergency Department Group. The lead author here is Jonathan K. Oshkovarek, and they're with U.S. Acute Care Solutions. And this is an article describing the success of one of the tried and true methods of change management: shame and sticks. There is no carrot here. Described in this study as the United States Acute Care Solutions Emergency Department Staffing Group and their approach to reducing opioid prescribing by their physicians. As you might have heard, there's a wee problem in the United States with respect to opiate misuse. And one of the ways opiates become available in circulation is by prescribing by clinicians. Emergency physicians, as we've previously described on this podcast, are far and away not the largest contributor to the problem, but that hardly absolves us of responsibility to reflect on areas for our own potential improvement. The data here reflects a pre and post retrospective design associated with a prolonged cultural focus on reducing opioid administration. Phase 1 of their intervention was the shaming, a blinded clinician dashboard showing relative opioid prescribing rates site leaders had available and could share with clinicians as they saw fit. This phase lasted about 6 months. Then the stick. The blinded dashboard became available to all clinicians, and any outliers were contacted by national leadership by both friendly email and, if persisting in excess prescribing, friendly telephone conversations. So, which of these worked? Honestly, it's hard to tell. There's no control group, leaving us to effectively imagine whether there's a difference between the trends in the pre-intervention cohort and the ultimately lower levels of opiate prescribing by the end of the measurement period. It is easier to tell, however, what clearly did not work, and that was the initial dashboard sharing with clinician leadership and individual sharing, which resulted in zero change in prescribing trajectory. The stick, however, with individualized feedback from national leadership, seemed far more effective at rating in outliers, with both advanced practice practitioners and physicians whose prescribing was in the fifth quintile, that's sort of the upper 20%, dropped by about 30% after individualized targeting, while other quintiles had little apparent temporal change. This isn't terribly profound from a change management standpoint. Passive and general messaging can have some effect on culture overall, but direct, personalized intervention and education is far more likely to have both immediate and sustained effects, and indirectly change the overall culture. The data in this report describe its effect on opiate prescribing, but a similar intervention can be applied to CT utilization or any other quality metric adherence, where the data in this report describe its effect on opiate prescribing, but a similar intervention can be applied to CT utilization or any other quality metric adherence remains substandard. The data in this report describe its effect on opiate prescribing, but a similar intervention could be applied to CT utilization or any other quality metric where adherence remains substandard with substantial practice variation.
Yeah, it's not surprising, right? You get called into your boss's office, it's one thing. You get called into your boss's boss's office, it's another thing entirely. But yeah, if you want practitioners to do something, shaming them and punishing them or threatening to punish them, sure, is sure to work.
Yeah, I mean, this is not unique to emergency medicine. This is not unique to our industry. A little bit, one more email, saying, hey, here's your whatever it is, here's where you stand in comparison to everybody. Here's a metric dashboard in a practice environment in which we are getting constant feedback with metrics and dashboards. How do you prioritize one over the other? Well, you're going to prioritize the one where you get a phone call from the national vice president of quality, who's indirectly implying that your employment may or may not be compromised by your failure to adhere to rein in your practice variation. So, this is not unique to emergency medicine, but here it is, a window into what Acute Care Solutions has been working on.
Yeah, if you want to influence or change practice, this is a good way of doing it. Whether this change in practice actually makes a difference is another thing entirely. All right, well, why don't we move on? So our next article, subsequent buprenorphine treatment following emergency physician buprenorphine prescription fills, a national assessment 2019 to 2020. And the lead author is Bradley Stein. So I think it's fairly clear by now that buprenorphine prescription following a presentation to the emergency department for opiate overdose saves lives. But what we don't know is how often after a prescription by an emergency physician is that patient getting continued treatment. And so these authors conducted a retrospective analysis of pharmacy claims, capturing an estimate about 92% of prescriptions filled in the U.S. They identified buprenorphine prescriptions filled between February 2019 to November 2020, written by emergency physicians. They then calculated the rate at which patients subsequently filled buprenorphine prescriptions from another non-emergency clinician and the frequency with which subsequent filled prescriptions were filled by different types of prescribers. They also looked at how the pandemic affected these rates. So they identified over 22,000 prescriptions written by emergency physicians filled for buprenorphine naive patients. They were most commonly paid for by Medicaid and were most commonly in metropolitan areas. Only 28.5% of the patients subsequently filled a buprenorphine prescription written by another clinician. Adult primary care and advanced practice providers were the most common physicians to fill these prescriptions. These rates were slightly lower after the pandemic, but not by much, really just dropped by 3.5%. So, the study has a number of limitations. Most notably, they only are able to identify patients who had their initial prescription filled at a pharmacy, and so they may have missed certain patients. They're also unable to determine whether these patients received an alternative MAT, like methadone, rather than simply nothing. That said, I think it's compelling data, and it's kind of in line with a lot of studies that we look at where, treatments are started in the emergency department that require ongoing therapy from a primary care practitioner, and a lot of times they're just not continued. And so while, we do a lot of work to increase the rates of buprenorphine prescribing in the emergency department following an overdose, this data obviously shows we also have to focus on whether these patients have the appropriate follow-up to continue their care long term.
And I suppose by we, you mean like the healthcare system, because
Yes.
we're burdening the emergency physician with not only getting the buprenorphine, managing all the other problems that the patient may or may not have presented with in the emergency department, and then also arranging for their, primary care follow up or continuation. I mean, so it's not futile. I mean, some people did get their buprenorphine started in the emergency department, and they went on to have continued medically assisted therapy for their opioid addiction or opioid overdose or so on and so forth. So it's not futile by any stretch of the imagination, but this definitely shows the effects of our fragmented healthcare system, and then this vulnerable population that probably needs even extra supports to get the follow-up and continue the treatment that they need. So this is it's a sobering look at this. It's not futile to start buprenorphine, but it's a place where you absolutely have to do better.
Yeah, to be fair, we don't even know if it's not futile, right? There's no control group. You could say, like, if you just give these patients referrals and they follow up, the same amount of people would be on buprenorphine in 1 month. We don't know. And like this is the conversation you have with like starting warfarin in the emergency department for AFib. Like, if you don't have someone to prescribe it as an outpatient, does it really make a difference? And like, if they're not going to follow up, it doesn't matter. If they are going to follow up, it doesn't matter. What is the actual benefit of starting these chronic medications in the emergency department? It's hard to tell.
Well, I bet Rory could tell you specifically about atrial fibrillation and starting anticoagulation in the emergency department, because that's our entire R01. but yes, yeah, we see the same sort of thing with antihypertensives and other things that we think about starting in the emergency department that would be good for people's overall long-term health, but we don't necessarily know what's going to happen to them later.
Yeah, but as you said, a sobering look.
And that's divorced even from patient-oriented outcomes as opposed to a surrogate.
Right.
So we're just talking about surrogates with prescribing, not actually although we have done many articles here where the surrogate is actually correlated with morbidity and mortality for this specific disorder. But we're still talking about surrogates. Anyway. All right. The next article that's in this issue we're going to talk about is called Design and Implementation of an Agitation Code Response Team in the Emergency Department. Our lead author here is Ambrose Wong, and this institution is Yale University. And it's kind of an interesting report regarding the formation of an agitation code team in the emergency department. The goal of having such a team, as well as this structured, protocolized approach, was to reduce the use of physical restraint for patients suffering from acute agitation in the emergency department. It is always the goal to use the least restrictive form of treatment for agitation, as increasing intensity of intervention increases the likelihood of consequences for individual harms for the patient. And this is quite an extensive report, and it details what is essentially a 7-year saga of redesign of the approach to acute agitation in their inner city emergency department. The details are in the manuscript, but effectively it involves 3 years of bi-weekly meetings with a task force, as well as a rollout of a nonviolent crisis intervention training involving verbal de-escalation and team-based approaches to patient and staff safety. The ultimate product of this extensive planning phase is an overhead code alert, like a stroke or a trauma or a sepsis alert, in which a team of at least 4 or 5 or 6 security and clinical personnel respond to a resuscitation bay for the treatment of a patient with acute agitation, supported by protocols for safe de escalation and handoff to other clinical areas of the emergency department. Like the other pre post design mentioned earlier, it's very difficult to see whether this intervention worked. Back in 2015 and 16, right when this sort of saga began, 1.1% of all emergency department visits required physical restraints. In their transition phase, while designing the intervention and rolling out education, restraint use declined to 0.9% of all ED visits. Finally, in their end product phase, spanning 2020 to 2021, use of physical restraints occurred at 0.8% of visits. So, an absolute reduction of 0.3% across the 5+ years of design and implementation. And then, of course, the interrupted time series analysis here is just chaos confounded by the pandemic and makes it extremely aspirational to consider these measurements reliable, let alone build on that by tying the perceived improvement directly to the intervention as opposed to the entire cultural change. Then, as you can imagine, this is just another resource burden on the department, on top of all the other time sensitive diagnoses for which clinicians are haunted by quality metrics, including stroke, sepsis, STEMI, and trauma. This is very clearly an important issue and very important for this specific hospital and those like it, in which 1 in 100 patients are requiring physical restraint, meaning there are likely even more requiring significant de escalation or pharmacologic treatment for agitation. These are some very smart folks who put very serious effort into this problem, and it's an interesting descriptive report, but these data aren't robust enough to draw any substantive conclusions regarding this specific approach.
Yeah, and I guess I often wonder, like, what do they mean by they reduced the amount of physical restraints? Did they just hold the person down until they fell asleep after they gave them the medication instead of putting them in a restraint, right? Like, what are
Well,
they
4
actually getting?
points, I
Sure,
don't
but
know. Like,
like,
it's probably, additional rounds of pharmacologic therapy with additional
yeah,
physical restraints until they took effect or something like
like
that. I mean,
you can give someone medical therapy and 4 point them and take it off when they fall asleep, or you can have your 5 security guards hold them down until they fall asleep. But you're essentially serving the safe purpose, right? Like, so how are they actually accomplishing this? Are these patients that they would have otherwise, you know, used physical restraints and chemical restraints, and they were somehow able to verbally de-escalate them, or is this simply they just changed their culture of not using physical restraints?
yeah, and it'd be nice to see. I mean, so physical. I mean, restraints are bad, and people do get injured in restraints. But that is also a rare outcome. On top of the physical restraints already being a rare outcome, so it's really hard to actually trace this all the way back to an actual change in a patient oriented adverse outcome as well, because it's such a rare occurrence and such a rare which only has rare complications. So I would have liked to have seen not just this surrogate of physical restraint use, but actually other patient-oriented adverse outcomes.
Right.
And then, of course, any kind of it would have been nice to see the unintended consequences of this if there's other resourcing issues and costs associated with this as well. I mean, other than the training program, obviously, there's hours of training for the staff involved too.
Right, exactly.
Which is valuable training. I'm sure it's great, and it probably has general benefits outside of this specific situation for other patients as well. But yet again, that's still a cost and a burden and an extra responsibility for the clinicians.
I did like their little diagram with the patient in the center in the bed and all the staff surrounding them, which is not like what usually we have, where the patient's in the corner of the room with a chair, holding a chair up, and everyone's trying to get all of them.
Just a chair, not a gun. Okay, wow, you guys are pretty chill at your hospital.
Yeah, but no. I mean, all joking aside, it was a really, it was quite a large effort, and a lot went into it. I just would have liked to see a little more granularity of the data. All right. Our next article is using CDC's National Syndromic Surveillance Program data to monitor trends in U.S. emergency department visits for firearm injuries, 2018 to 2019. And the lead author is Marissa Linswald. So this is a really interesting concept. The authors use near real-time syndromic surveillance systems to examine patterns in firearm injury. This kind of tools were originally implemented for early detection of disease outbreaks such as bioterrorism, and basically they're used to identify like almost instant or rather quick monitor trends and clusters and outbreaks. And so Using the CDC's National Syndromic Surveillance Program, the authors identified non-fatal firearm injuries throughout the country. They identified a total of 132,000 plus firearm injuries that occurred over their study period. It was about 61.6 per 100,000 ED visits. Not surprisingly, the rates of male injuries exceeded those of females about 7.7 times more often in males than in females. And males experience a significant positive trend in firearm injuries. Males experience an overall increase in the rate of firearm injury ED visits over the study period, as did females overall. When they looked at it by region, among males, there was a significant increase in the rates of ED visits for firearms in the Northeast and Southwest. And among females, they saw a significant decrease in firearm injuries in the Northeast, but an increase in the Southeast and Southwest. Neither sex showed a significant increase in the Midwest or West. So, I think it's an interesting study, more so with what you could potentially do with this kind of data going forward. This kind of data that they have is fairly general, and I'm not sure how much you can take home from these findings, but you can see how this methodology can be used in the future to assess, certain changes in gun laws around the country and how it affects presentations to the emergency department for firearm injury. That, of course, is assuming that we never get changes in gun laws. But if we can, you can kind of see how you could use this type of study methodology to kind of track these trends. So from that standpoint, it's a really interesting study.
Yeah, I mean, this is not a study that's looking at specific rates of gun violence necessarily, but more so the actual utility of this program for the measurement of this, and then using it as a research tool to measure future public policy interventions. So, if this is your area of research and your bag, as it were, this is going to be an interesting tool to use to measure the effects of any kind of interventions towards gun safety that, in theory, emerge over the next coming months to years.
Yeah.
Or the other way around.
Right.
Or loosening of gun restrictions,
right.
which seems to be more likely than not.
I think that's the point, right? You can look at both, right? So, we know that certain states have actually seen a loosening in gun laws over the last few years, and you can see how those affect outcomes as well. So, it could be used in very interesting ways.
Indeed. All right. The last article from the May issue that we're going to talk about here is called Managing Patients with Acute Visual Loss. And our lead author here is Jonathan Edlow up at Harvard Medical School. And this is just really a nice little review article for folks to take a look at regarding the causes of acute visual loss in the emergency department. There's very little here that's specifically novel with respect to any under-recognized causes of loss, and pretty logically breaks the diagnoses down by the sort of the anatomic system of the eye, either being structural issues within the eye, neurovascular issues affecting the retina, and then etiologies affecting the central nervous system. The primary bit that's probably evolved since a portion of our current emergency medicine workforce trained is the idea of utilizing ocular ultrasound for the diagnosis of posterior ocular problems, such as retinal detachments, retinal hemorrhages, and papilledema. While I agree the use of ultrasound is an appropriate adjunct to other methods of examinations, its performance characteristics to experienced hands are probably not sufficient to conclusively exclude some of these diagnoses, let alone less experienced providers. And there's also a fair bit of text devoted here to promoting central retinal artery occlusion as a type of stroke and activating code stroke with the goal of treating with fibrinolytics. This is somewhat in contrast to the American Heart Association's 2021 scientific summary on the topic, which notes a paucity of evidence on the topic. And rather than Dr. Edlow's phrasing that TBA should be considered, notes that TBA may be considered. The risk-benefit discussion ought to include the limitations of the current evidence. I would remind the readers and listeners these expert clinical management series represent one individual's approach and do not set a standard of care or guidance for practice. Multiple clinical trials addressing this question are ongoing. But setting that issue aside, there are certainly enough pearls here to be worthy of a read for any practicing physician to reactivate some of those memories of knowledge from training and prior study.
Yeah, I think that's key. I mean, he does, some of the stuff does kind of step outside what our current data suggests. But, for the regular clinician, this is a great review. I spend most of my time in the critical care department or the high acuity segment of the emergency department. So I don't spend much time doing eye complaints anymore. So when I do, a review like this is very helpful to kind of reorganize how I'm thinking about these diagnoses and these complaints.
All right, brilliant. And you made it through.
I made it through. So that wraps us up for another month. I'm going to try to rest my voice and come back sounding somewhat more audible for the June issue, which we should be recording shortly. But until next time, any comments, questions, or concerns can be reached at annalsaudio@acep.org. Otherwise, until next time, this was Rory speaking on Ryan Radecki, and this was the Annals of Emergency Medicine podcast.